Welcome once again to yet another episode of Connecting the Dots podcast. And today we are joined by a pioneer in health financing, a science leader whose work has helped African governments make evidence-based and cost-effective decisions that have led to real-life impact, from shaping Kenya's universal health coverage strategies to helping Rwanda triple its budget to fight non-communicable diseases such as cancer, diabetes, and stroke. His work is a masterclass in persistence, precision, and purpose. He doesn't just craft policy recommendations, he follows through, knocking on doors, booking meetings, and making sure those ideas don't just sit on the shelf. We talk about often invisible work, often in research into policy, what it means to prioritize health interventions when everything feels urgent and there's not enough money, and why Africa needs more trained health economists in its corner. My guest is a Kenyan expert, an African seasoned health economist and Calestous Juma Science Leadership Fellow, Dr. Vincent Okungu. He has extensive experience advising health sector on planning, financing, and policymaking across the continent and globally. His work just does not focus on domestic health financing, but also includes sustainable research and development financing and healthcare equity and value for money. Karibu sana, Dr. Okungu.
Thank you very much, Juliet. And it's a pleasure welcoming me today, Connecting the Dots.
Thank you. Vincent, you once dreamed of becoming a teacher like your father. Clearly, you looked up to your father. Can you take us back to that time? And what was your upbringing like? And how did your path shift from the classroom to the person that you've become today, a health economist?
Thank you. My father was always my hero.
Yeah.
When I look at a male father figure, my father was always my hero. He was a teacher and a good one. He taught me English and always looked up to be like him. Although in my interaction with him, because he passed on when I was still a minor, in my interaction with him, he always saw me as somebody who is highly educated, and he kept putting that in my head. So I dreamt of doing more than just one degree, and I didn't know that moving on like that, it would push me out of the classroom. Although I wouldn't say I am totally out of the classroom because I still teach at the university. But my version of being like my father was more in a high school or a primary school like he was. Where that shift came from to be more than just being a teacher, because I do more than just being a teacher.
Mm-hmm.
Is that I think his shaping of my life and putting in my head that I should be more than what he is. And that is what encouraged me to do more than just, go beyond teaching. Yeah, so my upbringing, I think, was very good. I don't have any. If you look at my primary, high school, university history, I didn't have any disciplinary issues. And I think that's enough testimony that my upbringing was okay. I grew up normal in the villages, weekends hunting squirrels and birds and occasionally digs. And just that was normal life. Yeah. And supporting my mom during harvesting and all that. So I grew up a normal village boy. And
So Vincent, you went to primary, secondary school, and then university. What did you study in university, and how did you move from there into now health economy?
Yeah, actually, at high school, I dreamt of being a lawyer. And I didn't meet the cutoff points, unfortunately.
Yeah. Maybe thank God.
Yeah. So I did education, actually.
Mm-hmm.
And but something in me was just focused on research. I wanted to understand, basic health care access issues. Why are people dying at home? Why aren't they going to hospital? So at that point, I started just writing online. I used to frequent WHO offices, the World Health Organization offices, to read articles on healthcare, summarize it, and send it to All African News Agency. They could pay me some money, but a lot of times it was just articles that interested me.
Yeah.
So I grew up to understand how research would contribute to solving access issues, the healthcare access issues. And I contacted one of my lecturer friends. Do I mention the name?
You can.
One of my lecturer friends, Dr. Humphrey Ojuang, and he told me, I know an institution where you can do research. So he introduced me to Institute of African Studies, University of Nairobi. But then I realized that the kind of research they were doing, much later, already enrolled in the program, that the kind of research they were doing was not mine, because they were doing more research focused on social anthropology and so on. So I kind of deviated from that. I was like, no, this is not what I'm looking for. So within that, looking for work and so on, and somebody at Cambridge Wellcome Trust recognized my work. I did an interview, and I was recruited as a research assistant. From that point, they saw my potential. So they recommended me for training in health economics at the University of Cape Town. So I did my master's in health economics at the University of Cape Town. I did my PhD, same university, health economics, health financing. And then I did also, as part of my professional development, I did a number of certificate courses. It's health economics modeling, decision analytics, and so on,
And what does a health economist do? What has your career looked like?
Yeah. So health economics, people may not know, but it's quite broad.
Yeah.
So I focus on a small area, health financing, and looking at how economic principles are applied in healthcare, and how best to get value for the money that is invested in the health in the health sector. So basically, that is my primary role, but also how to translate evidence that is generated into policy to inform policy decisions at government, at national and continental level. But also, a section of my work involves evaluation of interventions. So I want to look at if you invest $10 in healthcare, what do you get out of it? How many lives can you save with that? How many lives can you save? Something like that.
So if we're looking at the state of our health financing, in Kenya, on the continent, how would you rank us? Are we doing well? Are we not doing too well? Who's being left behind? And then what are the gaps?
Yeah, let me look at that question from a continental level and then narrow it down, or rather global level and then narrow it down. So if we look at the policy focus globally, it is access to healthcare for all. I think as late as 2023, there was the Lusaka agenda that encouraged countries to reform their health systems, achieve universal healthcare, so that everybody can access quality healthcare when they need it, and not based on their ability to pay, but when they need it.
Yeah.
But if you look at the history, the last decade, in terms of country progress towards universal healthcare, because it's not new. It's something that started maybe 2 decades ago.
Okay, universal healthcare. That is, yeah.
Yeah. So if you look at the progress with universal healthcare, it's kind of stagnating because in the past decade, if you look at the period 2009 to 2019, you see that the number of people that are accessing essential health services has actually decreased.
Okay. And by essential, we are talking
We're
about
talking just what
vaccines?
A country can afford, a basic package of care.
Okay.
Preventive care, basic curative care.
Yeah. So
if
like
you
vaccines,
look at that number,
for example. Yeah.
That number has actually increased. So we are talking about 4.9 billion people who globally who cannot access healthcare, essential health services.
That's more than half
population of India and China combined.
Yes.
Yeah. So that's a number that's is
terrible.
staggering. Yet we're talking about progress to universal health coverage, countries investing, and so on and so forth.
Yeah.
Again, at least between the same period, 2000 and 2019, the number of people getting impoverished, the number of people getting poor as a result of paying for healthcare has increased by 4.9% globally.
Okay.
And another staggering statistic is that people who are lacking basic food, who are people who are reallocating their expenditures from basic food, education, everyday expenditures to meet healthcare needs, what we call catastrophic health spending, has also increased by 3.9%. So from the Sustainable Development Goals to from the Millennium Development Goal, is it Millennium?
The SDGs.
The MDGs, the Millennium Development Goals, and then to the Sustainable Development Goals.
Yes.
The SDGs.
Yeah.
As much as there is emphasis on universal healthcare, there is stagnation across the world, especially in developing countries. And then if you look at the continent itself of Africa, we are still very far from meeting our health financing goals. And what are these goals? I'll come to the Abuja target at some point, but that is the first goal that we are supposed to meet. And that is half a century ago, that government should spend at least 15% of their budget, at least 15% of their budget on healthcare.
Yeah.
Just about 4 or 5 countries have met that goal.
And on the continent.
On the continent.
Yeah.
Because that's a continental goal.
And this is a declaration set 50 years ago.
A quarter century ago. That's 25 years
25 years ago, yeah.
Yeah, these were declarations set by the African heads of state in Abuja.
Yeah.
So I call it Abuja Declaration.
Yeah.
So just about five countries have met that target. Others have met it and moved and dropped again.
Regressed.
Yes. But just 5% have met that target. If we talk about reducing out-of-pocket expenditure to less than, out-of-pocket is when you have to pay for services when you need them in your pocket. So when you look at the out-of-pocket expenditure, the WHO states that this should be less than 20% of the total health expenditure in a country. Less than 20%. But when you look at Africa, more than 20 countries, still, if you look at the level of out-of-pocket spending, the out-of-pocket spending is still 40% of the total health expenditure. So, and then the other goal is per capita health spending, where the WHO says per capita is, if you look at, if I should give you $86, and that should be enough to fund your basic healthcare needs for the year. So per capita, per person health spending on the continent, WHO says worldwide should be about 86, at least $86 per person per year.
So $86 being given by the government to spend on healthcare?
No, total, whether it is government, donors, households, private sources. if total health spending in this room we are 5, and we have $100, that $100 should be divided equally among us. Each of us gets $20.
Yeah.
So that's per capita.
Okay.
So if the total health expenditure in a country is 1,000, that is what per capita means. That 1,000 should be divided equally in the with the total population in the country.
Yeah.
So that WHO says should be $86 per person.
Per person, yeah.
The WHO Africa office is more ambitious. It says it should be $246 per person.
Okay.
But if you look at what we have now, we have about I wouldn't say more than 15 countries have met that target.
Oh, okay.
So we are still very far from meeting these our health financing goals.
Yeah.
Part of the reason is the difficulty or the challenges in collecting revenue because of the informal nature of the economy and also the inefficiencies in collecting public revenue to fund healthcare. Of course, we talked about informality as informal economies and the difficulty of collecting revenue and so on. But to me, that's more of an excuse because we have countries that have successfully collected revenue.
Yeah.
Even though the informality in those countries is more than 80%.
Yeah. What examples?
If you talk about Rwanda, for example, how are they managing their universal healthcare system, which is, for a country of its level, it's the best in the world. Because it's able to...
In the world?
Yeah, at its level.
Yeah.
It's a low-income, tiny country, very low GDP.
Yes.
So what is our excuse?
Yeah.
If our GDP is, I don't know whether it's 3 times more than 1. So what is the excuse of Kenya, Tanzania, Ethiopia, or any other, Nigeria, one of the wealthiest countries in Africa? What is our excuse not to be able to provide essential services in the country? However, we can say that a number of African countries as well reformed their health systems to ensure that there is reduced out-of-pocket expenditure as well as increase in access to services. So the way they structure the universal health systems, Tanzania is approaching it slowly. South Africa has been struggling. Mauritius is quite okay in prioritizing what kind of diseases to include in their package of care. So there are a number of countries that have made progress in increasing access and reducing out-of-pocket expenditures. Now, if we talk about who is being left behind, so if you consider the statistics I gave you, about 4.5 billion people lack access to healthcare, about 4.9% increase in poverty as a result of seeking care and so on.
Yeah.
So you can see that the people that are being left behind are the same people being targeted by governments to government for coverage. They're poor.
Yeah.
People who cannot afford care. And probably if you look at the recent funding cuts by the US government, UK, Netherlands, Germany, these are the same people that have been benefiting from external aid. And if you leave out the poor, you look at maternal and child health. As a week ago, the US government could not dispatch drugs meant for contraceptives in Africa. And that is about $9.5 million worth of drugs. So instead of giving it out, they kind of banned it.
Okay.
It's settled back. So we have people who are systematically left behind, the poor, the women and children, even the health workers themselves. Because in all this reform work, which brings a lot of workload, the health workers are poorly paid, poorly motivated, and so on. So part of the team that is being left behind by these reforms, and also people with chronic illnesses, because there is no policy that I know of in the continent to finance long-term care, especially for chronic illnesses.
Yeah.
So, and then if you look at now, I would want to say that there is no shortcut to universal healthcare. And I think if you asked me, the approach that we have used as a country is kind of a shortcut.
Yeah.
Because in 2 years, we want to provide free healthcare for everybody, comprehensive. The benefit package is very expensive.
Mm-hmm.
But then we target just a small pocket of the population to finance. So you can already see problems with the social health authority. And part of that problem is not just the rush of implementation that is causing these implementation issues, but also the people being targeted, that is the poor, this coverage. They do not know what they're entitled to.
Exactly.
And they're not empowered to demand for the services they're entitled to. So there is that disconnect between the policy intent and the implementation practice. Yeah.
So I want to ask you a quick question.
Yeah.
As a person who, say, is seated in the village, do you think we make a mistake when we centralize healthcare, and that maybe we should make that decision making go further down into communities, into maybe in Kenya, the whole county governments, allow the county governments to have a bigger say in how health financing, is rolled out. And by that also incorporate the county citizens to make their own decisions. Because I can imagine if I'm in the village somewhere, in Northeastern, I really feel that my decision is being made at the capital city in Kenya, and also across the continent. I don't want to say Nairobi is an example, maybe Abuja, Lagos, Cotonou in Benin, which you were recently there. Do you feel like maybe there should be some form of decentralization and control of expenditure closer to the people, as opposed to at a central where, decisions are being made? And I mean, even your reference point to the US government and the Europeans, this sort of global control of people's life, I think, might be the challenge that is causing us to lead into poor rollout of the universal healthcare coverage or even primary healthcare.
Yeah, I mean, different countries have different strategies of financing.
Yeah.
In Kenya, financing healthcare is quite devolved. The counties have the autonomy to decide on how they budget for their healthcare.
Okay.
That is in addition to the universal health coverage policy, the social health authority. So the social health authority is actually centralized. And it's important to be centralized because we need a bigger pool for risk sharing. So if we have a small pools of funds in every county, we will be collecting very little money. And some counties have very high disease burden. And with that high disease burden, the pool of funds available to them is small. They will not get the care they need.
Yeah.
So other counties have a very low population. And if the low population, low disease burden, for example, if I'm just using it as an example, then they might have more healthcare than they need. So pooling at national level is important because it gives everybody a chance to access healthcare where everybody, rich, poor, are paying according to an ability to pay.
Yeah.
Rich, poor, everybody is in that single pool. So even if you're poor and you can't afford healthcare, somebody somewhere already paid something that they're not using. So you get the chance to use that.
Yeah.
So I would, in terms of insurance coverage, health insurance coverage, I'd advocate for larger pools at national level. However, in terms of decision making, what goes into that pool and how that pool should be financed, the sources of funding, that should be a national debate that starts from the grassroots way up to the top, so that you take into consideration what the people's concerns are, the political acceptability of those decisions, the disease burden community level, so that it becomes something of evidence, a pool that is evidence informed.
Mm-hmm.
So all the services that will be purchased resonate with the population health needs. So that is important, that we engage the population to decide what kind of services they need, how those services should be financed. That is essential. If we talk about, you mentioned about funding cuts in the US. So I think this was already happening even before USAID was disbanded.
Okay.
The donors were already reducing their funding for not just the health sector, but the overall aid basket was reducing.
Okay. That's interesting.
All developing countries. So what was not expected is the drastic reduction.
The abruptness,
where we within a few months we punch in $80 billion hole into the health sector. So you see, on an annual basis, we are expected as a developing world, as Africa, to generate at least $70 billion to plug in the funding, to plug in the gaps left by the funding gap. So the funding cut. So that is a really big challenge. And the immediate loser there, apart from the groups I mentioned, is also R&D financing in Africa, which has been substantially financed from external sources. We only contribute 1.1% of global research and development funding. And I think with that drastic cut, we are going to see a real big hit on R&D initiatives on the continent. So it is important that we think through what we want to do as a continent.
Mm-hmm.
And one of the issues that I've always looked at is, if we really want to respond in a sustainable way to fund our health sector, then we have to look at evidence-based declarations. So if you look at the whole package of Abuja Declaration, and I'm surprised that this is a declaration that is still informing
decision-making,
advocacy and decision-making on the continent. It is obsolete. It should have been disbanded years ago. Why? Because one, even countries that have achieved the Abuja target, there's no difference in health outcomes with the countries that have not achieved it. Two, it didn't have a timeline. So when do we want to achieve this target? Is it in 22nd century? Is it in 2063? Is it in 2015? We don't have a timeline.
I hope not.
So we are saying, no hurry in Africa. Let Abuja target be our target. Whenever we achieve it. It is also contradictory to current policy on universal health coverage. Because we can't say, if you achieve Abuja target, you will achieve universal health care. You'll be able to provide essential services for everybody in the country. So this is a declaration or a call, whatever it is, that should be disbanded and replaced with a more evidence-based, well-structured call that does not look into input from external sources. Because Abuja was very heavy on, we are going to provide 15% of the budget, and external sources will also come in to provide this percentage and so on. So that is not working.
Clearly.
So it should be restructured or disbanded, and then a better evidence-based strategy put in place for the continent.
I mean, Vincent, here on Connecting the Dots podcast, we always like to straddle controversy. So it sounds like it will now be breaking news that on this podcast, we advocated and championed for the Abuja Declaration to be disbanded.
Exactly.
And we demanded that the world, the continent, the African Union as well, European Union, to push for a new declaration, maybe one, the Nairobi Declaration. It would be nice to see that.
Precisely.
Yeah.
And then let's let Africa push it. Let the AU push it. Because the last time I mentioned about disbanding Abuja target.
Yeah. April.
Somebody said, no, is this guy even a health economist?
Yeah.
I'm like, yeah, I'm a good one.
Yeah.
But show me that Abuja target is working. When do you want to achieve it?
Yeah.
So we are 25 years into that declaration and we're heading nowhere. If you look at the Kenya health policy, I think 2019, 2030, it talks about achieving Abuja target by 2030. And I'm like, are these guys serious? So, and if you say that, no, let's change that, nobody wants to listen.
And because, I mean, with the Abuja Declaration, we said 15% of expenditure to health. What is the current reality for Kenya?
We talk about 15% of government budget going into the health sector.
And for Kenya?
I think Kenya is about, I don't have the exact figure, but it's 8 to 11%.
Okay.
But it keeps fluctuating. Sometimes it is 6%, sometimes it is 7, 8, 11. So it keeps going up and down. For reasons I don't know.
And I mean, even if we were to think about 25 years ago, Kenya's population was not where we are at right now. So I think you're 100% right that they need revisions. Timelines need to be set, even if it's a 5-year timeline. You know, whenever our politicians, this is a message for our presidents, whenever they come with their manifestos for 5 years. So why are we holding on to a 25-year declaration? But Vincent, I want to move you very quickly to the smart economics, you know, being a health economist, smart economics of R&D. And if we look at a country like the US, and I think the data that I have here, it says the US sees an estimated 2.2 return on every $1 spent in medical research. Surely when you're knocking on doors and speaking to African governments, do you ever make this case to them that, you know, spending on healthcare is actually a good thing to do? And also from a health investment perspective, even forgetting about saving lives, which is very important. Health investment, it's a good return on investments. When you push that message, what's the feedback, or how receptive are they?
The characteristic of investment in R&D is that the common understanding, and it's the reality, that most of it, you're not guaranteed of returns. So you can invest $1 billion on product development and you fail to develop that product.
Okay.
You can invest $1 billion on a product and you actually develop the product, but the market doesn't take it.
Yeah.
So one of the unique characteristics of R&D is that there is no guarantee on returns. But that's a risk that everybody should take.
Right.
But that's one of the risks that we're not able to take. And I think to drive R&D forward in a developing world like Kenya, for example, and Africa, for example, the government should take the lead in taking the risks in funding R&D.
Yeah.
So that it shows the way for the private sector to come in and take over some of these potentially impactful projects that can yield very high returns. I had a discussion with one of the vice chancellors of the university, not University of Nairobi, but
another university.
Yeah, one of the and he's very passionate about R&D, especially in agriculture.
Yeah,
and he showed me how R&D can be impactful economically. He showed me how they imported bull semen. I don't know which country it was, but somewhere in Europe, and developed new breeds of cattle, very high quality. And he said these cattle are going for a very high price and the demand is so high. So just a very simple example of return on investment in R&D. But with our policymakers, that hasn't really sunk in, that investment in R&D can actually be fruitful for the economy.
Right.
And I've had interviews, had discussions, whatever, with policymakers. And if you look at the trend in funding R&D in Kenya, for example, it's not like, let's start with funding R&D in Africa.
Mm-hmm.
We were at 0.3% of GDP in 1996. And I think that's 30 years ago. We are at 0.33% now of GDP.
We have plateaued.
No, it's a plateau.
Yes, we have not even grown upwards or downwards.
So it's a continental problem.
Yeah.
So if you see any increases, the 0.3%, if you see any increases in R&D funding on the continent, it is Northern Africa and probably South Africa.
West Africa?
No, Northern Africa and and South Africa.
Yeah.
So if you remove Northern Africa and
Sub-Saharan
South
Africa.
If you look at the Sub-Saharan Africa alone, we have actually stagnated in putting money into R&D.
And why is that?
This is the same problems. Maybe I can argue is competing priorities. We are not taking research products into decision making. We don't understand the value of R&D.
Yeah.
Yeah. So
I think that's the point.
Because sometimes the returns take years. And probably we are not patient enough to invest in those years. We want to invest now.
What is more patient than if they would have started 25 years ago with Abuja, they would have been very far by now.
Abuja should go. I mean, it was it had good intentions to increase funding to the health sector. That has been overtaken by events. Yeah. And it should be restructured.
So it sounds to me like some of the points that you're highlighting on health financing, I mean, by our policymakers is first the appreciation of the smart economics of R&D and that, there's good return on investment. And I think, earlier you said citizenry should be empowered to champion their own leaders to invest well. And as a taxpayer, I would love to also urge government. Sometimes there's wise investments. And I think, if we look at also investment, sometimes you make an investment and it works. Sometimes it doesn't necessarily work. Yeah. I'm going to ask you 3 quick points. We like to connect the dots on this show. Mm-hmm. So let's zoom out a little bit and ask you very quickly, what are the 3 things that you feel need to shift at a systemic level to make sure that health financing is equitable, more sustainable, and more aligned to our public health goals?
Yeah, systemic changes. I think at a continental level, 1 is a restructuring of the Abuja target. I've said that.
Yeah.
2, if you look at investments in the continent overall, the wide variations in health outcomes in relation to the aggregate health financing indicators, total health expenditure, expenditure per capita, total health expenditure relative to the national wealth, the wide variation, those indicators vary. Mm-hmm. And there are also very wide variations in health outcomes, even in countries. And I'll give you an example where some countries have met the 15% government funding for the health sector.
Yeah.
Others have not.
Yeah.
But you don't see any difference in health outcomes.
Interesting.
So I think the first thing that we need to look at is, a deeper contextual analysis of the design, the architecture, and the operations of the existing health systems, and why there's all these differences. We understand why there are all these differences in health outcomes.
Yeah.
And then we should be able to now come up with evidence-based decisions on how to move forward. The other point is on, at national level, we have problems with accountability.
Yeah.
So how do we invest in systems that would make us better use the resources that we have at our disposal?
Right.
And some of the most corrupt countries on the continent also have some of the worst health outcomes. And we published a paper on the effects of corruption on health systems and outcomes. And you can see a direct relation between corruption
and health outcomes.
And I think the first thing we can, and it is a difficult one, because it's very difficult to hold governments accountable, is to come up with systems that will make us better use the resources that we have. I saw, and I think that is just a reaction, not really a solution, where in Kenya, where hospitals that have been, that are suspected to have been involved in fraudulent activities with the social health authority, the government cuts links with them and transfer their patients from those hospitals to other facilities nearby. That to me is a reactionary
approach.
Rather than a systematic approach to solving a very huge global problem, especially in the developing world. So I don't know the solution yet, but I think investments in digital technologies and so might help to avoid things like a malaria patient being hospitalized for 30 days, or some patient somewhere in one of the counties getting 5 amputations. So those kind of things can be easily avoided by technological investments and so on. And then the last part, I think we can draw lessons from countries that have actually succeeded in developing countries, that is, that have succeeded in having sustainable universal health coverage systems. Thailand.
Thailand.
A good approach because they have 3 funding pools. And I thought when we were drafting the Kenyan policy for UHC and the financing strategy, I thought that is what the first thing they would think about. Have a pool dedicated just for the formally employed people. They can contribute there, and that's their pool.
At that level,
for a start, because I said no shortcuts. For you to reach a point where there is equity, it has to be progressive.
Right.
So we have to start somewhere where we are and have a pool, formal sector. And then for the informal sector, the jobless and so on, have another pool that is funded by everybody through direct and indirect taxes. But what we have now is one pool and everybody should be there. One section of the population is funding it without consideration of how the informal sector would be involved, if they're involved at all. Because what we have now is a system that attracts what we call what it was the term? I'm forgetting my insurance terms.
But premiums.
But a system that attracts people who need it at that point. Once they benefit from it, they're off. I'll give you an example where somebody in my village once is sick. They go to hospital, they are told, do you have
insurance?
Do you have social health insurance?
Do
you have SHA? They call it SHA. Do you have SHA? They say, no, I don't have SHA. They'll pay 3,000 shillings and then you are registered. But the reimbursement that these hospitals are going to claim is probably 30,000. But you are registered for SHA. You get your services, maybe you will fall sick another 1 year down the line. But you have used 30,000 and you're not contributing anymore and you're out of the system.
Right.
So the system should be should be less contributory. Like contributing premiums should not focus on that at all when it comes to an economy that is as informal as ours. It should focus more on what kind of taxes, direct, indirect, can we collect from the population, everybody, have it under the treasury and budget for the health sector for all. And targeting basically people who are unemployed and working in the informal sector. Because everybody pays tax.
If you had an unlimited health budget for just one day and you could fix one thing in the system, no bureaucracy, no politics, what would you do first?
Well, I think I would want to fix the public finance system first. I would pay the pending bills.
Okay.
As long as they're genuine.
Yeah.
I would like to pay the pending bills. But after that, I would want to focus on essential services for primary healthcare. So I would make sure that the primary health system is equipped and is supplied with drugs and other non-pharmaceutical supply, non-drug supplies.
Yeah.
For the longest time, because that is where preventive care takes place. And once you invest in preventive care, the health system becomes less expensive. Yeah.
Okay, interesting. I actually thought for a section, I thought for a section that you would. I thought for a second that you would actually target corruption, go anti-corruption, Kagame style, actually.
Yeah.
So we like to ask our guests, what African scientists, or maybe even in your case, health economists, given that you are fine being between, what health economists, African science, do you look up to and you'd like us to host on this episode?
Who do I look up to?
Yeah.
As a health
Who
economist?
Inspires you? Yeah.
I don't think there is a health economist who inspires me more than my supervisor.
Okay.
The PhD supervisor.
And who is this?
That was Diane McIntyre.
Okay.
I think she's retired now.
Okay.
But
where was she based? Where was she based?
She's based in Cape Town.
Okay.
The University of she retired from the University of Cape Town.
Yeah.
But still very active. She's I think the executive president of the International Health Economics Association.
Mm-hmm.
Yeah. So if there is a health economist that inspires me, that would be her. Yeah, there are others as well, but if I were to mention one, that would be the one.
That would be the one?
I mean, get all those ideas, then we chase them.
And two other ones? Two other ones not in the health economy field.
Dead or alive?
Can be both?
I mean, if I were to look up to a scholar, I'll look up to Ali Mazrui.
Okay, why?
Because I think this guy was ahead of his time, one of the top 100 scholars in the world, published a lot on culture and basically social issues on the continent. But all of them are dead. I mean, only McIntyre is alive, and I look up to Mazrui. I read a lot of his books, Cultural Forces in World Politics.
Yeah.
Very inspirational. And I would look up to Calestous Juma.
Juma.
Just publishing on technology and how to reform the cultural food systems in Africa. I think that's also very inspiring. Very engaging book published by Calestous Juma. So.
And now, perhaps as we are wrapping up, what would be your parting shot when it comes to domestic health financing, and looking at geopolitics globally, what's happening with funding cuts? What's your takeaway or call to action?
As I said, we don't have a shortcut to making sure that everybody has access to quality, equitable healthcare. There's no shortcut.
Right.
So every country has its own contextual issues that it needs to look at as they want to have sustainable financing for the healthcare, including R&D. So the first thing that a country should ask itself is, where are we as a country? And where do we want to go? That's the very basic first question. Where are we with this? Where do we want to go? If it is coverage, universal health coverage, okay, we want to achieve universal, equitable health, universal health care. Who should we target first? With what services? It has to be progressive. So you've answered those two first questions. Then now, how do we finance it? What models should we use? Because a lot of African countries, if you look at the policymakers, they first rush to the models.
Yeah.
Okay, we are going for social health insurance.
Like SHA.
Like SHA. So it's a model first before you think about where are we, what services, who do we target. So I think for us to make impact as a country, as a continent, we need to ask ourselves, where are we? Where do we want to go? Who should we cover? With what services? And how should we finance it? And that applies even to R&D. Yeah.
So obviously your message is targeted mainly to our decision makers and our leaders. What would you say to our general public, our audience who's listening and watching this podcast? What action can I take as a citizen, say, of Kenya, of Africa?
Where we have failed as middle class, I think all of us are in middle class.
Yeah.
Is to hold our leaders accountable.
Right.
So leaders make wrong decisions. And instead of coming up and say, let's have a dialogue over this, what we say is, how do we cope with those bad decisions? So I think the population, beginning with the middle class, should hold their leaders accountable. In Malawi, what they've done is quite innovative. Is if a government declares that they will invest 4% of GDP on health, then the justice minister has to sit there, finance minister has to sit there, the health minister has to sit there. They draft a law.
Wow.
That
Obviously.
This is the law.
Yeah.
So we have to make a decision when do we want to achieve this, but it's on the law.
Okay.
They're not roadside pronunciations that we are going to reach 2% of GDP for R&D, and then there are no accountability mechanisms.
Yeah.
So there has to be accountability mechanisms driven by citizens.
Right.
And then that is how the policymakers, the politicians will be accountable for their decisions and for the citizens.
I mean, that's a fantastic example. I was going to ask you what accountability looks like for, for us as citizens. I mean, you know that Kenya has been on the driving seat in terms of Gen Z's protests, and pushing for the government to do the right thing. However, the example of Malawi is a really good one of, giving an idea, a practical solution to governments and making sure that these are enacted into policy making. Vincent, Dr. Okungu, it has been an absolute pleasure having you here.
Thank you for having me on Connecting the Dots. I've said things that wouldn't be bothered me, and I'm like, can I put all these in paper?
Yeah.
Thank you so much.
No, thank you so much.
Yeah.
A huge thank you to our guests. You've had us unpack health economics. We've also talked about smart R&D investments that our African governments should be doing by using taxpayers' money. We've talked about debunking or bringing down Abuja Declaration. Maybe we have just created our very own declaration. No shortcuts when it comes to healthcare financing, as well as practical solutions that are currently being used by countries such as Malawi that the rest of sub-Saharan Africa can begin to use. And that's up on this episode of Connecting the Dots podcast. Remember that every idea starts with a simple dot. It's what you do with it that is the game changer. Stay curious, stay bold, and keep asking why.
Thank you.
Thank you.